Hi, it's Dr. John Raymond Baker, DC, and today I'm going to talk about a procedure that some folks have that maybe shouldn't have had, and some folks have that probably should have had, and that's called a tracheostomy. Now, one fault that I often find with the allopathic healthcare system is that when they're trying to get you to accept or agree to a procedure or a medication, they're always heavy on the side of giving you the possible benefits, or sometimes just saying this is what you've got to have without even giving you options, but very, very light on telling you what the adverse reactions or the bad side effects or the negative outcomes to that procedure or medication might be. And in fact, from state to state, if you look at the laws about quote-unquote informed consent, and even among the state boards of the various states, they're kind of easygoing on that issue, in that they don't mandate the healthcare provider, usually the doctor, of giving you all the negative side effects of a medication or the possible bad outcomes of a procedure, but they don't even mandate that the main ones be given to you. They're very skimpy on what shall conform to informed consent. And of course, informed consent is what they're supposed to obtain from you before applying a procedure or giving you a medication. But how can you have informed consent, or how can you give informed consent, if you are only shown the positive effects and not shown the negative effects? And a very good example of this is the fact that often they will tell a family member or a person, you've got to have a tracheostomy. Tracheo meaning the trachea, and stomy meaning an opening or a mouth. From another language. So tracheostomy is creating an opening in the trachea. Now, they often will say, well, that's something they need because they're having respiratory failure, they're having problems, and that's where the conversation ends, without them telling you that for some people with a certain profile, it's basically a death sentence to give them a tracheostomy. Why? Why is that the case? Well, first of all, if you're applying why as to why don't they give you the negatives, is they want you to go along with them, and they don't want you to say no. They want you to give them the okie doke. That's fine, doc, whatever you say. And why do people die from tracheostomies? Well, there can be numerous reasons. There can be a variety of reasons. One would be heavy weighted on the class of patients you are. For example, if you're an older patient who is immunologically compromised, who has been subjected to various nosocomially acquired infections like MRSA or C. diff or all the various infections that one is prone to obtain or prone to be infected with in the hospital, that infection itself can cause septicemia, can be a cause of death. But I don't want you to just take my word for it. I want you to listen to what people at the National Institutes of Health, people at Johns Hopkins University, people at the Mayo Clinic say. And I'll have to read some of this, so you'll excuse me for glancing down, but this one is from the Journal of Intensive Care Medicine, and it's in PubMed if you've ever done much investigation of resources. You'll recognize PubMed as being a fairly authoritative source. The abstract is the purpose of the study was to determine hospital and post-discharge survival and functional status as follow-up in elderly patients receiving tracheostomy for respiratory failure, and determine if these outcomes differed between the young elderly, that's 65 to 74, and the older elderly, which is greater than 75 years of age. This was a retrospective chart review, so they basically took charts and were looking backward. Only one half of hospital survivors survived for an additional year. So the people that got the tracheostomies, only a half of them even lived for a year. Those discharged ventilator dependent were more likely to die. Of the 20 participants of the study, most had fairly good emotional and social functioning, but were extremely physically. So basically saying, they were fairly good folks as far as emotional and mental functioning, but the health of their respiratory system was a problem. And this one is kind of odd because they basically say that there's poor mortality as far, a lot of people die after tracheostomy, but then they say it's not related to the procedure, and it's kind of odd that they draw that conclusion. This is from the otolaryngology, that's a hard one to say, otolaryngology head neck surgical publication. And their objective was to investigate morbidity, complication rate, and mortality in oldest old patients who undergo tracheostomy. The medical records of 64 patients greater than 85 years of age who underwent standard or percutaneous tracheostomy between 2001 and 2005, that 4-year span, in a tertiary care hospital were reviewed for in-hospital and out-of-hospital mortality, complications, and decannulation rate. 28 were discharged from the hospital and all remained tracheostomatized at that time. Postoperative mortality had not been related to the postoperative procedure, and the mortality rate reached 75% within the first 3 postoperative months. Now, I think that's kind of odd to say they had this procedure, 75% of them had serious problems, including but not limited to death, and 93.8% within the first year. So almost every one of them, with 1 or 2 surviving, died within the first year after the tracheostomy, and 75% in 3 months after the tracheostomy, and they draw the conclusion that it wasn't related to the procedure. In fact, in the conclusion, they say tracheostomy is a safe surgical procedure in the oldest old patients. Well, number one, I would say there's no such thing as a safe procedure in the oldest old patients. There's some that are safer than others, but I believe it's a little bit disingenuous to say that it's a safe procedure. Obviously, if 3/4 of them die 3 months after the procedure, maybe it's not as safe as you're saying. The high rate of the postoperative mortality is not related to the procedure itself. The possibility of permanent stoma should be considered and discussed with patients and their family during preoperative counseling. So I think that's a bizarre study. When you have a procedure, 3/4 of the people that had the procedure die in 3 months, and almost every one of them die within a year after, and then you just blanketly say, oh, it's safe though. It's kind of a bizarre thing, but so it goes. Johns Hopkins, fairly well recognized source of information on health issues. Complications and risk of tracheostomy. Early complications include, but not limited to, bleeding, air trapped around the lungs, pneumothorax, air trapped in the deeper layers of the chest, pneumomediastinum, air trapped underneath the skin around the tracheostomy, subcutaneous emphysema, damage to the swallowing tube, the esophagus, injury to the nerve that moves the vocal cords, i.e. the recurrent laryngeal nerve. Tracheostomy tube can be blocked by blood clots, mucus, or pressure of the airway walls. Blockages can be prevented by suctioning, humidifying the air, and selecting the appropriate tracheostomy tube. Later complications include accidental removal of the tracheostomy tube, accidental decannulation, infection in the trachea and around the tracheostomy tube. Windpipe itself may become damaged, or for a number of reasons include pressure from the tube, bacteria that cause infections and form scar tissue, or friction from a tube that moves too much. Then you have delayed, which I would think are the same as later, but delayed complications include thinning, erosion of the trachea from the tube rubbing against it, also known as tracheomalacia, development of a small connection from the trachea windpipe to the esophagus, the swallowing tube, which is called tracheoesophageal fistula, which is basically you're doing something bad there, creating a tube that connects two things that aren't meant to be connected. Development of bumps, granulation tissue that may need to be surgically removed before the decannulation, i.e. removal of the trach tube, can occur. Narrowing or collapse of the airway, and this is a very serious one, above the site of the tracheostomy, in essence, clamping off possibly requiring an additional surgical procedure to remove it. And then once the tracheostomy is removed, the opening may not close on its own, meaning the tubes remaining in place for 16 weeks or more are more at risk needing surgical closure. Now, those are things that you're not going to hear from a doctor that's proposing that you or a loved one gets a tracheostomy. And they're important things for you to know. Now, who is a high-risk group? The high-risk groups include children, smokers, alcohol abusers,